Welcome to today's Neuropathy Association webinar, What New Neuropathy Research Can We Be Hopeful About? Presented by Dr. Stephen Maynard and Dr. Douglas Zakhodny. And let me introduce our first speaker for our program today. Dr. Stephen Maynard is Adjunct Professor of Neurology at Indiana University School of Medicine. He received his medical degree from Wayne State University School of Medicine in Detroit, Michigan. He completed a residency in neurology at the University of Illinois and a fellowship in epileptology, also at the University of Illinois. While in Chicago, he taught at the Abraham Lincoln School of Medicine. He now teaches neurology at Indiana University School of Medicine in Terre Haute, Indiana. Dr. Maynard serves on the Speakers Bureau for PAM Lab, a Nestle Health Science company. With that, I'll turn today's program over to our first speaker, Dr. Maynard, who will begin our presentation.
Thank you very much for asking me to come back and talk about peripheral neuropathy again this year. And peripheral neuropathy is one of the most common diseases in neurology. It's right up there with migraine headache. It affects at least 20 million people in the United States, so a very common problem. The peripheral neuropathy itself is simply damage to the peripheral nerves. There are three major categories of peripheral nerves: the motor nerves, which control the movements of muscles; the sensory nerves, which bring in sensation from the body; and the autonomic nerves, which control functions that you're not aware of, such as digestion and blood pressure and bladder function. The symptoms of the neuropathy depend on which nerves have been affected, and any combination of the motor, sensory, or autonomic nerves can be affected. The damage to nerves usually involves the longest nerves, and so these nerves are the most susceptible to damage, and so the symptoms usually begin in the feet. They will then slowly ascend up, say as far as the mid-shin to the knee, and once that happens, then the symptoms will begin in the fingers. The neuropathy scope is very, very large here. Diabetes is without question the most common cause of peripheral neuropathy. Alcoholism, by the way, is number two. And a very large percentage of patients who have diabetes are going to develop the neuropathy with the pain and the numbness and tingling that I'll talk about in a few minutes. At least a third of the patients who have neuropathy have no known cause. They're not a diabetic, not an alcoholic, don't have thyroid problems, and we simply do not know the cause, and this is often problematic for the patients, but I tell them that this is a common problem, and we'll treat the neuropathy no matter what the cause is, even if it's not known. The rest of the patients will have multiple causes, such as thyroid problems, vitamin deficiencies, etc. We'll talk over in a little bit, and that's part of the workup for the neuropathy. If the sensory fibers are involved, you're going to have a large number of sensory symptoms from the damage of these nerve fibers, which have a lot of different terms, which can be rather confusing, so I'm going to define them all for you. Paresthesias are spontaneous sensations that come on without any stimulation whatsoever. They can be described as a pins and needles tingling, a creepy crawly feeling on the leg, a sensation if water's running down, can be sharp, shooting, burning pains, and these occur for no reason whatsoever. These symptoms are often worse at nighttime. Dysesthesias are an abnormal sensation when you touch something. Say you pick up a glass, you put your socks on, and this sensation may be perceived as a very unpleasant burning or painful sensation. Anesthesia is actually more serious. This is a lack of sensation. It makes common sense that you have sensation in your hands and feet to protect them. When you lose the sensation, you're now prone to injury, and this is always a major concern with the diabetics. If they can't feel something sharp on their feet, they may get a cut, and then that cut can become infected, and that can lead to major complications. Other symptoms are allodynia, which is a very painful sensation coming from a non-painful stimulus. The most common complaint I see with my patients are that when they put their socks on, they have a very unpleasant burning sensation in their feet. Walking on the floor is unpleasant for them. If the patient has their socks off at nighttime, just the sheets rubbing against the feet at night can be very unpleasant for the patient and unpleasant. Hyperalgesia is an exaggerated pain response. Say if they do get stuck with the pin or something, that can be much more unpleasant for the patient. I've seen this just in the laboratory where the patient's getting their blood drawn, and what would be perceived as a normal needle stick is a very unpleasant sensation for the patient. There's also impairment of position sense. Every joint in your body has position sensation, which sends a signal to the spinal cord in the brain to let the brain know where those joints are located. You lose the sensation in the neuropathy, and therefore, literally, your brain doesn't know where your joints are, and this can lead to a very significant problem with your balance and walking. The patient begins basically walking as if they were drunk. They are prone to falling and injuries. A common complaint I see in my office is that the patient will tell me that when they close their eyes in their shower to shampoo their hair, they fall over and hit the side of the shower stall. This is because they've lost the sensation from the position sensors in their legs, and they're relying on their vision to keep themselves balanced. They close their eyes, and over they go. If the motor nerves are involved, this leads to a wide variety of symptoms, mainly weakness in the muscle, which of course makes sense. But these symptoms can also include a lot of muscle cramps, which often are worse at nighttime, and it may be brought on by exercise or activity during the daytime. The muscles may begin twitching. This is called a fasciculation, and usually will be present over a long time and not lead to any major deficit. There can be significant loss of muscle. The muscles begin atrophying and shrinking up because of the loss of nerve input, and this can be very severe in some patients. We also are losing changes in the skin, where the skin becomes very thin, it becomes very shiny, the hair stops growing, the nails become disfigured, and you can look at a patient with diabetes and you know from the looks of their feet that they have the neuropathy from the motor symptoms. The autonomic symptoms are also very important, and as I said earlier, the autonomic nervous system is controlling functions that the body's not aware of, but when these functions are impaired, can lead to a lot of symptoms. The autonomic nervous system is responsible for the food moving through the gut and digesting your food. So if these nerves are not working properly, you can have constipation, diarrhea, a feeling of we call early feeling of satiety, because the food is not moving through the gut properly, and this is called the gastroparesis, which is a problem with your diabetics. The autonomic nerves also control your blood pressure, your heart rate, and your pulse, and this can cause problems with either a high or a low pulse. It can cause a sudden drop in blood pressure, making you very dizzy, even to the point of passing out when you stand up. The genitourinary system can also be involved with problems with bladder and bowel function and sex dysfunction in the males. The autonomic nerves also control sweating, and this can lead to problems with hot and cold temperatures causing abnormal sensations with the sweating. So when you have a patient who's presenting with a peripheral neuropathy, you want to make sure that that is for sure what you're dealing with. There are other conditions that can look just like a neuropathy. If the patient has poor circulation to their arteries, will cause some of the symptoms. The patient can have pinched nerves in their back and spinal cord that cause problems, and they can have all sorts of problems in their feet, and this is where the podiatrist can help you significantly, and you want to make sure there's no other condition, and you can check these with a circulation test and your good neuro exam. The neuropathies are divided into two major categories called demyelinating and axonal. Demyelinating means that the nerve fiber has lost the protein coat, which is literally the insulation cable that keeps one nerve from not talking to another nerve. Then the axon is the nerve cable itself, and neuropathy can involve one or the other or both. And in the case of diabetes, we really feel that both are probably pretty much involved. A test called an electromyogram nerve conduction velocity, which I'll go over in a second, can help determine which category of neuropathy that you have. There are many blood tests that can be done to look for causes of neuropathy. Some of the neuropathies are genetically inherited, and we can do genetic testing, but the problem is these tests are extraordinarily expensive and can be a limiting factor for the patient, depending on what their health insurance will cover. There are also certain antibodies that will direct an immune response against the nervous system. A common disease that we have in neurology is called lupus, but there are many others, and there are blood tests that can be drawn to determine if we have that type of condition that is present. A nerve and muscle biopsy can be done. I'm prejudiced in this procedure in that I feel very strongly that if you're going to put the patient through a nerve or muscle biopsy or both, it really should be done in a major university setting that has access to very sophisticated enzyme stainings, electron microscopy, because if you do the biopsy and just do the normal staining that a small hospital could do, there's a lot of information that you will miss. I send a patient for biopsy probably once every 2 or 3 years. We don't do that very much at all. So in evaluating a patient with a neuropathy, I cannot stress the importance of a good history and a good neurologic examination. You want to know from your patient, are there any other diseases present, such as kidney disease, diabetes, liver disease? You want to know what medications they're taking, because many drugs can cause the neuropathy. You want to know the family history, and especially if they had a bad history of, say, cancer, because cancer can cause nerve damage, and so can the chemotherapy. So history is very important. As I mentioned earlier on, that there are many other conditions that can mimic a neuropathy, such as spinal cord problems, arthritis, and a good neurologic evaluation can often help you differentiate between those two conditions. Tests that can be done are the nerve conduction study, where electrodes are placed on the arm or the leg. A current is passed between the electrodes, and you can measure how fast that current is going, and you can tell if it's at a proper velocity, and you can pick up nerve dysfunction that way. The electromyogram consists of placing a needle, which is actually an electrode hooked up to a machine. The needle is placed into the muscle through the skin, and we measure the level activity of the muscle, and different conditions cause different findings in that study. So those two together are very, very important. The skin biopsy is something that's, I think, done primarily by the podiatrist. They can measure the epidermal nerve density, and as this nerve density goes down, the symptoms of neuropathy goes up. A lot of the podiatrists I've spoken to will do this test at the baseline, then they'll begin treatment for the neuropathy and repeat the test in 6 months to see if the nerves are getting better and getting improvement. And it's always nice to show the patient that, hey, your biopsy is getting better, and what you're doing for yourself is of some benefit here. Autonomic tests can be done as well. You can pass a current through the skin, which will stimulate sweating. You collect the sweat, measure how much of the sweat is produced. If there's autonomic neuropathy, there'll be a decreased amount of sweat that's produced. Tilt table test is one that I do probably 8 to 10 times a week. Very common test. This is looking for the autonomic neuropathy with a sudden drop in blood pressure. I get patients who have the neuropathy, and when you stand up, it is the nerves going to the arteries in your legs that maintain your blood pressure and to keep it under control. And when you have a neuropathy, you've lost that input, and the blood pressure suddenly drops and you pass out. So that's a tilt table test. And by the way, just that you know, in our community, the test is only done with a cardiologist present, just in case that pressure does drop. Other tests can be done, as I mentioned earlier, is the nerve biopsy, which I only do under certain conditions where I'm looking for a very rare disease. And again, I like to have electron microscopy, and I'm standing for that. There are a lot of other tests that can be done for the neuropathy. The main test that I'm doing in a routine clinical lab is going to be checking for, of course, diabetes, looking for liver disease, kidney disease, looking for thyroid deficiency, vitamin deficiencies, and all these tests are done to see if you can find a cause for the neuropathy. And as I said earlier on, that there is a 30% chance all the tests come back negative, and you never find out the cause for the neuropathy. And so that concludes my part of the presentation here. I thank you for your time. I'm now going to turn the presentation over to Dr. Douglas Zakhodny. He is a professor in the Department of Clinical Neurosciences and director of the Neuromuscular Clinic for the Faculty of Medicine at the University of Calgary. He's the past president of the Peripheral Nerve Society and a member of the Neuropathy Association's Medical Advisory Committee and the Calgary Neuropathy Association. Dr. Zakhodny lab he established in 1988 has made contributions in the field of experimental diabetic neuropathy and peripheral nerve regeneration, particularly emphasizing the role of neurodegeneration in diabetic peripheral nerves.
I want to thank Dr. Maynard for starting out this session, and I'm going to talk about neuropathy, what it is, and how it can be reversed. And I'll start off with some definitions that can be a little bit difficult. The word neuropathy, all it means is damage to nerves or peripheral nerves, which are the essential structures that connect the brain and spinal cord to the rest of the body. So they're required to connect to muscles for movement and to the skin so that you can perceive sensation, or other organs, bones, and liver capsules, meninges, etc. So they provide sensation to the central nervous system. A polyneuropathy just means multiple nerves are damaged. And by polyneuropathy, we usually mean a widespread condition, and we often mean that it's involving the right and left side, so it's symmetrical, involves many nerves. And there's an important concept down here, which is that the longest nerves are often targeted first, and that's why the toes and feet have the very first symptoms of neuropathy. Some more definitions. Axons are the essential wiring of the nerve. So when they're damaged, their regrowth is slow and incomplete, and that's why neuropathies have difficulty recovering despite the treatments that are used. Myelin is insulation around these axons, and the myelin can be damaged alone, in which case it can be replaced around the wiring or around the nerve, and therefore recovery can occur more rapidly and completely. It gets a little bit confusing because there is myelin in the central nervous system. The myelin in the brain and spinal cord is a little different in its structure and its molecules, and so the disorders of myelin in the peripheral nervous system are different. Like CIDP, Guillain-Barré syndrome, they're different. So, for example, MS is a myelin disorder of the central nervous system. CIDP and Guillain-Barré syndromes are disorders of myelin in the peripheral nervous system. So some neuropathies are axonal, so they have axon damage and slow recovery. Others are demyelinating and can recover more quickly. This is just an image that we put together of our peripheral nerve, just to kind of give you an idea of what it looks like. There's an outer layer called the epineurium. There are these fascicles surrounded by tissue that's called perineurium, and then inside is what's called the endoneurium, where all of the active ingredients are, so to speak. So the axons and the myelin around them, and these fascicles, or the endoneurium, contains hundreds to thousands of axons. Here, this is just a schematic representation, but it's important because different neuropathies can involve different parts of this nerve. So, for example, in vasculitis, there might be inflammation around these blood vessels in the epineurium. In some conditions, this perineurium can break down. In many neuropathies, there's loss of axons or myelin or both in the endoneurium. Here is an actual peripheral nerve axon with its myelin laid out. This is a so-called teased fiber preparation where they lay it out. And along here at the top under lower power, you can see where the arrows are. There's little breaks. And these are what are called nodes of Ranvier. And I'm showing it in higher power here. It looks a little darker where the axon is here. That's where the sodium channels or the electrical excitability of the axon is propagated. So that's a very important part of the nerve. And we think some neuropathies, particularly painful ones, might alter proteins right there. Here's a cross-section or a transverse section of what a real peripheral nerve looks like. So again, here's our perineurial layer around the outside. These are epineurial parts. And then we're focusing in on the endoneurium. These little C's stand for little capillaries or blood vessels inside the nerve here. Here's a larger one with an A beside it that's called arteriole. This is the same one, just shown in higher power. And here's what the axons look like. You can just start to make out some of the ultrastructure inside of them here. There are other cells in the nerve that can have an influence in neuropathies called mast cells. And then there are very tiny fibers that we can barely see, and we would need electron microscopy to see that are called C or small fibers. So on the next slide here, I'm just showing you what might happen with demyelination. So you may remember that long axon I just showed you that had a node of Ranvier at one side and at the other. In between is called a segment, and here the segment of myelin is lost, so-called segmental demyelination. And if we look in cross-section, we see these nerve fibers are also very thin. This nerve has been demyelinated, and then the Schwann cell, or the cell beside it, its partnering cell, is trying to remyelinate it. So thin fibers. And this is a person that had CIDP, chronic inflammatory demyelinating polyneuropathy. So I'm just going to talk a little bit about regeneration now, and these are some schematics of all of the events that can occur when a nerve is trying to regenerate. And to give you an idea of the complexity of this, this is a sensory nerve here at the top, the cell body, and it's got its long axon stretched out with myelin segments around it, as I pointed out before. Then a cut injury occurs, and there's degeneration of these axons. Unfortunately, there's no way to rejoin this axon back up immediately if it's cut. There is an immediate message that occurs in these axons here to begin to degenerate, and it's irreversible. And that's so-called axonal degeneration. Some people use the term Wallerian degeneration, named after Augustus Waller, who was an anatomist. The rapidity with which this part is broken down is a determinant as to how successful subsequent regeneration will be. So we now know that this process, the faster and more efficiently occurs, the better chance of regrowth. And there's a lot of new research looking at what determines axon breakdown here. Some very, very interesting work that I won't touch on. You'll notice that the cell body has changed here, that there's changes in its structure, and the cells around the outside have enlarged. So those are what we call retrograde changes in the cell body. The nerve is reprogrammed totally to change from a maintenance role to a growth mode, to change to something else. And then it can begin to send out these little sprouts. And a lot of investigators have been looking at all of the genes that change to make this nerve into a growth mode. We notice here that these new cells enter macrophages to break down this distal stump, as I mentioned. And then lower down we have the new axon sprouts that are trying to regrow. And these are the Schwann cells that are along these axon sprouts, helping to guide them to regrow to target. The nerve then has to mature. The myelin has to mature. It has to reconnect to its targets that were there previously. So multiple steps, a lot of neurobiological information there. So I've already mentioned that axonal damage, the wiring damage, can be associated with only very, very slow recovery. Here's a patient who was in the intensive care unit for over a year with very severe axonal damage from Guillain-Barré syndrome. It's supposed to be a demyelinating disorder, but we know that some patients have axonal involvement as well, and that can lead to near permanent paralysis in some people. Here's a patient with a sciatic nerve injury. This photograph was taken 100 years ago, but just makes the point that major nerve trunk injuries in the shoulder or upper thigh, for them to regrow all the way back down to the leg to their distal targets doesn't happen as often or very much at all. So for a nerve to grow beyond the knee is unlikely, and that's an illustration of why regeneration needs to improve. So in summary, regeneration is essential for recovery from axonal damage, axonal neuropathies. It already occurs far too slowly, at the very best a millimeter a day. It depends on regrowth of the axon all the way down to where it belonged before, to skin or muscle. And for this, we don't have available therapies to speed this, and that's what we're interested in working on. So here are some slides just quickly illustrating some of these steps in the growth of nerves, and I'll walk through them again just very briefly. We have damage to the nerve, followed by regrowth of the axons, but they may not necessarily go to the right position. And that's what the next slide shows. It shows what are called neuromas in continuity, where the nerve has almost been cut completely, but there's a tiny strand left. But despite that connection, these nerves have not grown back down the stump where they belong. So the nerves are connected, but the axons have not grown through them. There may be a few axons in this particular instance and a few more here, but certainly not enough to regain function, motor function, sensory function. Here are some nerve fibers that are going around and around in a circle in the proximal nerve stump in this area here, instead of growing down to their targets. So just to illustrate that the axons don't always go where we want them to. Collateral reinnervation is another important mechanism for recovery after neuropathies. And in this instance, what happens is you may lose, and I'll just go back up for a moment, you may lose a nerve cell, as shown here, But to compensate for that, the remaining neuron spreads out axons or fibers into the skin in an attempt to compensate for the area of lost sensation to occur. So it's a completely different mechanism of recovery from neurological damage. Ideally, we'd like to have the whole population of cells there, but if we don't, the remaining ones can help to take over. To support growth, there are what are called growth factors discovered in the 1950s, and now a larger family called the neurotrophins, but there are a host of other growth factors as well, and there's been a lot of interest in having these growth factors as treatments for neuropathy to help the axons to grow back. However, the trials have not been all that favorable, in part because some of these growth factors only affect some fibers here. Here are two nerve fibers in a dish, and you can see they're sending all their axons into where the growth factors are. So you'd think it would be an obvious choice, and there's been a lot of interest, and we may still be able to use these growth factors at some stage, but it hasn't solved the problem yet. So, how do we improve nerve regeneration? If it's a traumatic injury, there might be surgery. You could try to reverse diabetes, although if there's neuropathy already present, the axons need to regrow. For autoimmune neuropathies like CIDP, you can treat with IVIG. If there's significant axon damage, you may or may not get complete improvement. And as I mentioned, growth factors are experimental, and the benefits in the trials have been a little bit mixed, so that's a bit controversial still. Some new approaches that we and others have been interested in. It turns out that if you stimulate an injured nerve for a period of about an hour after it's injured, the subsequent growth is improved. This is a finding discovered by Dr. Tessa Gordon at the University of Alberta, Dr. Brushard and Johns Hopkins, and other people have worked on this. Very interesting process, and more to come on that, I think, as some early clinical trials. Dr. Bruce Gold has discovered that a class of molecules called immunophilins, which were immune suppressor drugs, can improve regeneration. There's these molecules called ROA-ROCK. These are brakes on growth. Neurons have brakes on their growth, so they inhibit their own growth. And by releasing these brakes, you might be able to allow nerves to grow better. Strategies to prevent axon damage, that prevent axonal degeneration, will be important. And again, there's a lot of work there. And finally, what we've been working on are the idea that these so-called tumor suppressors, molecules that normally prevent cancer but are present in nerve cells and block growth. The difficulty is you want the neurons to grow and extend their axons robustly after an injury or after a neuropathy. So you don't want this kind of break on growth. So like ROA and ROCK, these tumor suppressors may be new pathways to allow regrowth to occur. P10 has gotten a little bit of press, and people are working on it, and retinoblastoma is a new one that we've just been working on. Just to make a point that none of this work can be done by individuals. There's a lot of people and stakeholders involved. The granting agencies are absolutely critical to this work. Highly qualified people that we've had the privilege to work with, all with different skills, right from summer students here to technologists, technicians, postdoctoral fellows, who will be our next generation of scientists, all working together. And we've in our own lab, we've had an absolutely wonderful team of people. Finally, the Neuropathy Association has constructed a slide here mentioning some new clinical research trials. These aren't ones that I'm particularly involved in, but the slide is here that they've put together. And I think all new trials will offer hope and are important. And then finally, people ask how to accelerate neuropathy research, and the Neuropathy Association has been putting together this national patient registry, which I think is an excellent idea to bring people together who are trying to find a little more about neuropathy, who may be interested in participating in research studies. So I think it's an absolute superb idea, and I would encourage anyone listening to be involved in that.